All right. Well, good morning. We'll get our meeting started. This meeting of the Board of Chiropractic Examiners is being held by teleconference. The date is Thursday, July 23rd, 2026, and the time is 9:10. The board's paramount responsibility is to protect the health, welfare, and safety of the public through licensure, education, engagement, and enforcement in chiropractic care. Members of the public may address the board during the public comment session. Public comments will also be taken on agenda items at the time the item is heard and prior to the board taking any action on said items. Those who would like to provide public comment will be limited to 3 minutes unless in the discretion of the board, circumstances require a longer period. Members of the public will not be permitted to yield their allotted time to other members of the public to make comment. Individuals may appear before the board to discuss items not on today's agenda. However, the board may not discuss or take action on these items except to decide whether to place the matter on the agenda at a future meeting. Please be aware this meeting is being recorded. We ask that you turn off all your cell phones or silence them, and we will now take the roll. Ms. Cruz?
Dr. Adams?
Present.
Oh, and would general counsel should also state whether there's anyone public.
Yeah, 101 Andrew Street, Sonoma, California. There are no public members present.
Thank you. Dr. Daniels?
Present, 1165 Park Avenue, San Jose, California, and there's no public members present.
Ms. Cruz, present. I am at 1625 North Market Boulevard, Suite N220, Sacramento, California, 95834. No members of the public present. Dr. Azzolino?
Present, 1545 Broadway, Suite 1A, San Francisco. No members of the public are present.
Thank you. Dr. Paris?
Present, 3455 Knighton Road, Redding, California. No members of the public present.
Thank you. And Mr. Sweet?
Yes, good morning. Present, I'm at 4100 West Alameda Avenue, 3rd floor, Burbank, California, 91505, and there are no members of the public present.
Thank you. We have a quorum.
Thank you, Ms. Cruz. Appreciate that. We will now go to agenda item number 2, public comment for items not on the agenda. We want to inform members of the public that they may address the board at this time. Advise that it's voluntary to give your name, and it will record in the official minutes of the meeting if it's provided at the time of your comment. Moderator, open up for public comment.
Hi, this is the moderator. If you would like to make a comment on the items not on the agenda, you may look for the raise hand icon at the bottom of your WebEx screen. And if you're a call-in public member, you may press *3 to raise your hand. We are displaying instructions and we'll give you a moment. No comments or raised hands. I return the floor back to you, Chair.
Thank you. Appreciate that. We'll now go to agenda item 3, the board chair's report. We've had a lot of things happening at the board in the last even a couple of months. This is a longer board chair report than I'm used to giving, so please indulge me a little bit. I first of all want to acknowledge the movement off of our board counsel, Sabina Knight. She served with us for 4 years. We loved her and enjoyed her spirit and her contributions to the board. She took a new role at Post, and we just want to acknowledge that she did some meaningful work with us, and we really will miss her. Having said that, we're excited to, excuse me? Sorry, I heard, no, okay. Having said that, I want to acknowledge our new board counsel, Christine Jacob. We're excited to have her as our counsel, and I'm sure that she'll fit in really well and help us continue our mission to strengthen our board and to enact regulations that are going to be beneficial for the safety and protection of the public. And we look forward to working with you, Ms. Jacob. I don't know if it's appropriate right now to allow her to introduce herself, Kristen. If not, we can probably wait till later if you need, or is now a good time?
Certainly, go ahead.
Ms. Jacob,
Thank
take a few minutes and introduce yourself to us.
Thank you, Dr. Adams, and thank you for that wonderful introduction. I am absolutely following a great attorney, Sabina Knight, so I have big shoes to fill there. So I think that was very appropriate. So I'm hopeful that I can help the board as well as she did, and I look forward to working with the board to ensure its mission of public protection. I don't know how much the board knows about my background. I've been with DCA since 2024. I was counsel for the Bureau of Real Estate Appraisers before this. So from 2024 to about June of this year when I got assigned over to chiropractic and other clients. Prior to that, I was in private practice for about 20 years. I was doing civil litigation. I represented attorneys, insurance brokers, and malpractice actions. And I also did a lot of business litigation. So I'm happy to be here and I look forward to working with the board.
Well, we're excited to have you. And it sounds like you've got lots of background and experience, and that can only add to our good fortune. So thank you and welcome. We also want to welcome Angela Taylor as the board's new administrative and policy analyst, and excited that she, for her skill set and bringing value for policy development, project management, and strategic initiatives at our board level. So we appreciate having you here. Angela, would you want to take a minute and introduce yourself to the members of the board?
Thank you so much. Yeah, Angelina Taylor. I come from the private sector, so this is my first state position, and I'm just really excited to be here. I've learned a lot. It is a great cause, and I'm very excited.
Wonderful. I think I misspoke your name, Angelina. Sorry, I think I said Angela. I meant to say Angelina. I apologize. So welcome. We're looking forward to working with you. And on a sad note here, we are going to be saying goodbye to Miss Tammy Herrera, who's been our assistant executive officer since I've been on most of the time I've been on the board. She's going to be leaving us on August 5th, 2026. After 18 years of dedicated service to the BCE, we're sorry to see you go, but you'll be taking a post at the Structural Pest Control Board, and we'll miss you, Tammy. So I don't know if you want to say a few words or not, but we'll miss you.
Thank you, Dr. Adams. Yeah, it's really kind of a bittersweet move for me. I love the profession. I love the board. I love the employees. So yeah, just a little bit of change going on. I'm staying in the department, so that's good. Still, mission is public protection and that kind of stuff. So I'm really excited for the change as well, to learn new things. And I appreciate all of you. Working with you all has been, really great. I've had the privilege to listen to you all formulate, the future of the profession. So it's been a privilege to listen to what you guys have done. And this board in particular, in my tenure with BCE, has really done a lot more than I've seen earlier on. So it's kind of really been exciting. And, working under Kristen, she's done a lot too. So I want to say thank you all for everything. It's been a pleasure. We may cross paths in the future. So I'm really excited for what the future holds, but I will always have a special place in my heart for chiropractors in BCE.
Well, thank you for your comments, and we will miss you, and we wish you well in your new venture. So thank you so much, and we appreciate all that you've done for us. Now, just a few comments here to wrap things up. The sunset review is kind of coming to a close. We are excited that we completed that process. It was a lot less painful than I thought it was going to be. And that in large part was due to Ms. Walker and her expertise in this area, having done it once before with Dr. Paris, made it a lot easier. And we were able to get, I think, just about everything we asked for except one item. So we're very thrilled about that. And so that's good stuff. We want to express our gratitude to the legislature for their thoughtful engagement. They really worked well with us and helping us get the things that we wanted and getting those things included. And it made it a pretty easy process. And again, Ms. Walker did a lot of the heavy lifting on that. So I extend appreciation to her for that. A lot of the board's proposals that we got implemented are really there to better equip us to fulfill our mandate for public protection, and our ability for enforcement, as well as the modernization of the licensure types that we're kind of moving into with a lot of the changes in chiropractic relative to telehealth and QME and other aspects of the profession that have been expanding. The Sunset Bill also included the addressing our fund condition, which I'm sure we'll discuss a little bit later, that Ms. Walker will embellish and a little bit more on. But a lot of these things that relate to fees and other aspects that will create a good glide path for our fund condition will be implemented as of January 1st, 2027. A little regulatory update, and that our strategic plan objectives and review of our regulations were completed at the last, we completed also, as it relates to regulatory changes, an unprecedented 8 regulatory packages were completed in 2025, and that's the largest that we've had in about the last decade. So pretty exciting for us and the things that we've accomplished, and we still have a lot of things in the pipeline, which we'll hear about later. The Administrative Law Office recently approved the board's proposal prohibiting the practice of chiropractic with an inactive license and repealing obsolete mental illness regulation, and those changes will become effective on October 1st, 2026. In relation to business modernization, we are transitioning as a board from our kind of manual, paper-driven processes to a more digital-oriented aspect with the Connect system. And so DCA has been working with us to get these new IT things in place, which will really expedite a lot of things as it relates to CE and other aspects of the board. The modernization is a top priority because it is the board's only major business process not yet to be automated. Once fully moved to Connect and other IT platforms, the CE records will integrate seamlessly with licensing files, reducing administrative burdens for licensees and staff, improving audit accuracy, supporting the board's long-term goal of achieving 100% CE compliance at the time of renewal through the primary source verification. So we're excited about these changes with the board, which will make things a lot more streamlined and quick and more efficient. We've been doing a lot in the last couple of years, as one of our goals from our strategic plan was more outreach. So our board members have been engaging more with stakeholders and licensees in outreach efforts, and I think that's made a big difference in the perception of the board in the profession as well. So kudos for us for doing a good job with that. And with that, that includes my chair report. So if there's any comments or questions from the board, please do so. Otherwise, we'll move to public comment. Hearing none, moderator, will you open up agenda item 3 for public comment?
Hi, this is the moderator. If you would like to make a comment on agenda item 3, you may look for the raise hand icon at the bottom of your WebEx screen. We are displaying instructions and we'll give you a moment. No raised hands. I turn the floor back to you, Chair Adams.
Thank you. Appreciate that. We will now welcome for agenda item 4, Ms. Tess Townsend. from the DCA's Office of Board and Bureau Relations, and she will provide us with an update on what's going on at the Department of Consumer Affairs. Ms. Townsend.
Hi, thank you. Can you hear me? I was having some audio issues earlier.
Yes, we can hear you.
Okay. Okay, so here is the update from the Department of Consumer Affairs. Starting with the Secretary announcement. On May 12th, 2026, Governor Newsom announced the appointment of Rohit Chopra as Secretary of California's new Business and Consumer Services Agency, which officially launched July 1st, 2026. Secretary Chopra previously served as Director of the U.S. Consumer Financial Protection Bureau and as a Commissioner of the Federal Trade Commission, where he led major efforts to crack down on junk fees, corporate misconduct, and unfair practices harming consumers and small businesses. We are excited to welcome Secretary Chopra and look forward to carrying out our consumer protection mission under his leadership. Return to office. DCA, along with other state departments, transitioned back to 4 days a week in office on July 1st, 2026, consistent with the governor's executive order, which was originally to take effect on July 1st, 2025. DCA issued a department-wide email with guidance surrounding telework agreements. DCA wants to recognize board leadership's efforts and partnership as we work together to support staff. Training updates. The next board member orientation training, also known as BMOT, will take place on October 21st. BMOT is an all-day virtual training which must be completed by board members within 1 year of appointment and reappointment to the board. Please register for the first available date to be in compliance. On May 26th, DCA launched its internal defensive driver training, available on DCA's Learning Management System, also known as LMS. This training is mandatory for state employees, including board members who operate vehicles on official state business. This 2-hour interactive session covers safe driving practices, rules of the board, required forms for state travel, and accident response procedures. Board members can register for BMOT or defensive driver training using LMS. If members have any questions on accessing LMS or would like to check to make sure you are in compliance with mandated training requirements, please contact us at memberrelations@dca.ca.gov. That's member, MEMBER, relations, RELATIONS @dca.ca.gov. That's it. Thank you.
Thank you, Ms. Townsend. Appreciate that update. Are there any questions or comments from the board? Hearing none, Ms. or the moderator, will you please open it for public comment?
Of course, this is the moderator. If you would like to make a comment on the DCA update, you may look for the raise hand icon at the bottom of your WebEx screen. We are displaying instructions and we'll give you a moment.
Dr. Paris, if I may, this is Council Christine Jacob. If we could just also call for public comment in the room here. There is currently no one present, no members of the public present, but in case someone does come in mid-item or mid-agenda item, that way, if they want to provide public comment here in Sacramento.
Okay.
I see no
Is
raised
there-
hand on WebEx.
Yeah, is there anybody there in public comment? Is that what you're suggesting, Ms. Jacob? Is there present in Sacramento?
Yes, yeah, just in case we have someone, since this is a publicly noticed site for the meeting, if someone wants to come in and make public comment. We don't currently have anyone here present, but maybe on each agenda item, if we could call for it, just in case anyone comes mid-agenda item.
So online, one call out online, a call out in person.
Correct.
For SAC.
Correct.
Okay.
Thank you.
This is the moderator. There is no public comment online at this moment. I return the floor back to you, Chair Adams.
Okay, thank you. And is there any public comment in any of the locations where anyone on the board is at?
No.
Dr.
There's no one.
Azzolino, Dr. Paris?
No,
No.
I'll let you know if anybody has any comments here. Thank you.
Okay. All right.
I'll announce too if any public attend.
Okay. So I'm going to assume then if I don't hear an announcement from you, rather than going through this every time, if anybody does have, just raise your hand and speak up. That way we'll cover that as well without delay. All right. Thank you. Agenda item 5, a motion or comment on any of the minutes that were provided.
I just had a question. It might be towards for Ms. Walker. Did we ever hear back on the Hurtado SB 980 bill? Several of us had a question on what that was entailing, and we were going to look into that. It was on the physical school exam.
We did. We tracked that bill, and it actually failed to make it out of committee back in April, so it died.
Okay, great. Thank you. I have no other questions, comments.
Any other questions or comments regarding the minutes? I'll entertain a motion to adopt January 16th, 2026 board meetings and April 16th and 17th, 2026 board meeting minutes.
I second.
I wasn't making a motion.
Oh, sorry. I'll make a motion then.
I was asking if
Yeah.
someone wanted to make a motion. Yeah.
Okay, I couldn't tell by the way you said it. I make a motion to approve the board meeting minutes for April 16th to 17th, 2026 and January 16th, 2026.
Second. Azzolino.
Dr. Azzolino has seconded the motion. So we will now open for public comment. Is there any public comment either at the locations? Let's open that up for public comment. Thank you, moderator.
Hi, this is the moderator. If you would like to make a comment on this agenda item or motion, you may look for the raise hand icon at the bottom of your WebEx screen. We are displaying instructions and we'll give you a moment. No raised hands or comments. I turn the floor back to you, Chair Adams.
Thank you. Okay. We have a motion on the table. Ms. Cruz, will you take the roll?
Absolutely. Dr. Adams,
Yes.
Dr. Daniels,
Yes.
Ms. Cruz, yes. Dr. Azzolino,
Yes.
Dr.
Yes.
Paris,
Yes.
Yes.
All right, motion passes.
Thank you very much. Agenda item number 6, review and possible ratification of approved Doctor of Chiropractic licensees applications. I will entertain a motion. Is there a motion to approve doctors?
I'll make a
Chiropractic.
motion to approve Doctor of Chiropractic license applications.
I second.
Is there any public comment? Moderator, can you open it for public comment?
Hi, this is the moderator. If you would like to make a comment on this motion, please click on the raise hand icon at the bottom of your WebEx screen or next to your name. We are displaying instructions and we'll give you a moment. No raised hands or comments. I return the floor back to you, Chair Adams.
Thank you. Ms. Cruz, can you call the roll?
Dr. Adams,
Yes.
Dr. Daniels,
Yes.
Ms. Cruz, yes. Dr. Azalino,
Yes.
Dr. Paris,
Yes.
Mr. Sweet.
Yes.
Thank you. Motion passes.
Thank you. A motion on the approval of new continuing education provider applications. Is there a motion to approve? Or any questions or comments?
I'll make a motion to approve the new continuing education provider applications.
I second.
Dr. Daniel seconds the motion. Moderator, can you open up agenda item number 7 for public comment?
Hi, this is the moderator. If you would like to make a comment on agenda item 7 or the motion, you may look for the raise hand icon at the bottom of your WebEx screen or next to your name. We are displaying instructions and we'll give you a moment. No raised hands or comments online. I return the floor back to you, Chair Adams.
Thank you. Agenda item number 8, we'll turn the time over to Ms. Walker for the executive officer's report and updates.
Sure. Thank you.
We need to vote on the last one.
Okay.
My apologies. My apologies. Thank you, Mr. Sweet. Ms. Cruz, would you call the roll for agenda item number 7?
Yes. Dr. Adams,
Yes.
Dr. Daniels,
Yes.
Ms. Cruz, yes. Dr. Azalino,
Yes.
Dr. Paris,
Yes.
and Mr. Sweet.
Yes.
Motion passes. Thank you.
Thank you for that catch, Mr. Sweet. Getting ahead of myself there. All right, we will now go to agenda item number 8 for the executive officer report from Ms. Walker.
Thank you. So I'm going to highlight a few items. Primarily, since the board last met in April, the focus has been largely on sunset, which we're going to address later in the agenda under item number 11. And then there's also been a lot of focus on our business modernization efforts in the Connect system, and then also our website, and then looking at our continuing education workflow. So I am very happy to report that efforts are well underway for us to begin building the CE functionality in the Connect system. We are basically working on a series of sprints, which are about, they vary in length about every 4 to 6 weeks of building incremental pieces of that system. So we started with building the continuing education provider dashboard. We now have functionality that allows us to connect individual users and basically authorize them to perform services on behalf of specific providers. So we've kind of built out that portion of it. Now development is underway on the biggest portion, which is the continuing education course application workflow, getting those applications in not only directly through the Connect system, but then also if we receive a paper application, how staff can add it in through the back office. So we're building out that. What's going to come next is we need the ability for providers to then go back in and do things like edit course dates and locations, and then also provide flexibility for staff to be able to update things like providers or instructors if they were to change for a specific course or make other adjustments there. So we're building that piece in Connect. I've also had quite a few discussions with DCA's Office of Information Services on the other portions of Connect. Of continuing education functionality. And we're likely going to take more of a hybrid approach to where that continuing education functionality is going to live in IT systems. So we're likely going to house the CE provider and course application workflows in the Connect system. But then when it comes to being able to provide a public search tool when it comes to available CE courses, we're likely going to instead leverage other existing DCA IT resources to put that directly on our website rather than put it in the Connect system as the acupuncture board has previously done. Some of the pros to doing that is we just get a little bit more flexibility on what it is we're able to provide, and then we can have better search tools and we can optimize it a little bit better by using DCA resources. So that project is also going to kick off soon with getting that on our website, which I'm sure everyone will be happy to see, because we can replace the those long lists of courses that are currently there and give people more of a search tool that's not only user friendly but just easier to navigate. The other piece that we're looking at for the CE workflow has to do with the records themselves. So we're in the testing phase right now of having the ability to do bulk uploads of continuing education records in Connect. And what that allows us to do is if we can go to individual providers and get their primary source records of attendees at specific courses, we can bulk upload those kind of records into the system, and thereby kind of avoiding having to have licensees individually store records themselves. We can automate some of our auditing processes. And we're also very early in discussions about potentially participating in a pilot program with another IT platform that manages CE records that could potentially plug into Connect as well. So we're looking at potentially 2 to 3 systems that are all going to kind of work together when it comes to this CE workflow. But like I said, the development efforts are well underway in Connect for the CE provider application workflow, which we anticipate having all of that done by this fall so that it's ready when we implement the new fees effective January 1st of 2027. And then we're going to follow behind with better search functionality, and then also the ability for basically making it easier on licensees to not have to manage their CE certificates. They're going to live in an IT system, and we can automate the auditing process, but also ease the burden of having to maintain that paperwork. Any questions on that effort before I move on?
Kristen, I assume the 3 systems you're talking about are not redundant. And was there what did you see with the acupuncture board using the Connect system, and why, what did you see that you didn't like about it?
So with the acupuncture board, the public search tool, the look and feel of it is rather limited. We can get a better tool if DCA takes the data themselves and then builds a website for us that syncs automatically. I agree with you. We're going to ensure that we're not being redundant with these. They're basically 3 pieces of the entire workflow that are supposed to work seamlessly together, but not step on each other.
Okay, great. Thanks.
Okay. Hearing no other questions on that. So like I said, I'll report back to the board when I have more details on those other two potential programs that will fit in with CE, but definitely very happy to report that we've made some progress already on building that functionality, and we're on target for launching this fall. Another issue that I discussed with the board, I believe it was at the April meeting, had to do with the potential for us to upgrade to a newer version of the Connect platform or stay on the current version. I'm still awaiting a cost estimate on that from the vendor, but when I do have that information, I'll put it on a board agenda so we can have the discussion and make a decision on that. We're in a path where we've built more and more on the current platform, so I'm leaning more towards maintaining the status quo, but if that recommendation changes, I'll certainly let you know. I've also just wanted to briefly highlight the legislative calendar. We're going to talk about legislation later on the agenda, but 2 key dates are coming up. August 14th is the deadline for bills to make it out of the fiscal committees, and then August 31st is the last day for each house to pass bills. So the legislature is going to reconvene from summer recess on August 3rd, and then we're going to have a few weeks there where bills either have to move or they're going to be dead for the year. I've got in there an update on regulations. As Dr. Adams mentioned in his report, OAL recently approved our regulations relating to the inactive license and the repeal of the mental illness regulations. Those both become effective October 1st. We've accumulated quite a few in the production phase, so we're working to get those moved to initial filing. One of the other pieces with that is we're evaluating the changes that are being made through our sunset bill to make sure that they're consistent with the text that we have in those production phase packages. Most of those can be updated through the existing authority for me to make non-substantive changes because our fee amounts are considered a non-substantive change. But if there's anything that requires a substantive change, that will likely come back to the board in October for approval. And then we're also in the process of, we just wrapped up the end of the 25-26 fiscal year. So we're developing all of our statistics on licensing and enforcement. I anticipate having those by the end of the month, and I will email them to the board for you to see. I am happy to report that as we were evaluating those, we kind of had a goal of ending the fiscal year with less than 175 complaints in our pending caseload. We did hit that target. We're at around 166 as of today. So very happy to see that. That's going to help feed into not only some of the improvements we want to make to our enforcement program, but also help us get our case processing timeframes down. Also within the meeting materials, I did include a updated fund condition. This includes fiscal month 11 projections, so it includes data as of May. We will have one more update that I'll release likely in early August, where it's going to have our final accounting of numbers for 25-26. As you can see, the updated numbers look a little bit better than the last projection that we ran, in that we're no longer projected to overspend our to spend more than we brought in through revenue this fiscal year. We've got a very modest surplus of about $21,000 based on their last projection. I also included in the meeting materials a breakdown of the DCA pro rata cost report for this upcoming fiscal year. Happy to answer any questions on that, but just primarily providing that as an informational item to the board. And with that, I'm happy to answer any other questions the board may have about my report or board operations.
Kristen, you didn't mention it, but it is in the materials. Did we get any feedback from the progress report that was due by Life July 1st?
We haven't gotten an update on that. I will look into that and report back to the licensing committee and the board.
Okay, and then just on that to-do list was clarification on the CCE academic calendar year. We kind of want those two bits of clarification.
Okay, yeah, I'll report back on those.
Yeah, okay, great.
Thank you.
All right, thank you.
Thank you, Dr. Daniels. Any other questions or comments from the board? Hearing none. Moderator, would you open up agenda item 8 for public comment?
Hey, this is the moderator. If you would like to make a comment on the executive officer's report, you may look for the raise hand icon at the bottom of your WebEx screen or next to your name. We are displaying instructions and we'll give you a moment. No comments or raised hands online right now. I return the floor back to you, Chair Adams.
Thank you. Appreciate that. All right, we will now go to agenda item number 9, the licensing committee report. They have been doing some amazing and important work in their committee, and a lot of heavy lifting on the part of Ms. Cruz and Dr. Daniels. So with that, we'll hear from Dr. Daniels.
Great, thank you. So as you have read in the packet today, there's potentially one ask on the language for the virtual care, and then AI language isn't quite ready, but we wanted to bring it to the board because we want to have a little bit of a discussion and input from that. So I guess we could start with the virtual care. If you just go straight to the draft language, the attachment 2, page 3 of 4, one of the committees asks is to have a brief discussion on feedback from the board members on emergency exception to initial telehealth. It's a minor detail, but the committee put an exception to the telehealth regulations just to be practical about operationalizing. A patient calls their provider. An example is they have BPPV. They may not be able to go through all of the paperwork, the consent, etc. They're a current patient, but that what we were asking for was a follow-up from that practitioner within a certain amount of days with the consent form, with a summary of the visit and any recommendations. So under section E, we put 14 calendar days. Just wanted first some quick feedback on what the board thinks about the time frame: 7 days, 10 days, 14 calendar days. So that's one specific ask, just to kind of move things along. And then obviously the other is we're looking for feedback on the draft language for creating the language for the virtual care. So I think I'll just pause there and see if the board members can give us some feedback.
Thank you, Dr. Daniels. I think the emergency time frame should be bumped up to sooner, given that if the patient is not better, given the example you provided, BPPV or something, I would hope that the practitioner would be moving them along and referring. And so I think it would be great to have that within a week, because whatever care we're rendering, the person should hopefully be better within a short period of time to be able to fill out that paperwork. So that's my comment on that. But I have a couple other questions for the committee. One specifically looking at section D, which is at the top of page 2 of 4, where it says the provider, section 1 of D1, the provider provide the patient their representative with the license full name and license number. It seems to me it's a little burdensome on the practitioner. If the person is calling to set up a telehealth visit, I would think that no different than if they walked into an office, they've already made the decision to work with that provider. So I mean, if somebody walks into our office, we're not providing them our license number, although it's on display. I don't see the reason why on a televisit we would have to go through that next step. And additionally on that, if we look down at number 3, down lower in the page, it says obtain the patient and their representative's verbal or written consent for the use of telehealth. I mean, if they're scheduling for telehealth, then I think that's already consent in that regard. We're not surprising people unless they believe they're coming in for a personal visit and they show up at an office and then the provider's not there and it's only telehealth. So I have 2 other comments. Would you like me to keep going and then we could take them up individually, or would you?
Yeah, go ahead.
The next page, page 3 of 4, B, the potential risks to patient confidentiality, data privacy, and information security. I think it's important that we ensure anybody that's doing telehealth is doing so on a HIPAA compliant platform. There's many people that are using traditional Zoom that is not HIPAA compliant. The professional Zoom is that it's an additional cost, but I think we need to include something in there stating that whatever platform they use is HIPAA compliant. And then lastly, page 4 of 4H, it goes right back to the patient emergencies, urgent conditions, providing any virtual care, establish a written protocol for identifying appropriately responding to patient emergencies. I would think that that is the same, whether it's telehealth or in person. So I'm not clear on where the committee was going on that one. So I just want some clarification on that, please.
Okay. Well, as far as the license, because the license number because it is available in office. And Ms. Walker, you can help clarify. We're going for streamlining it across both platforms so that the requirements are the same. And it's not, we have, as you know, there's patients that have cognitive issues, and just because someone is calling doesn't mean that they actually give their consent. So, and the standard is getting verbal or written consent when it is a virtual visit. And HIPAA compliant sounds great as far as the language. And as far as what was the comment on H protocol for the emergencies?
I just think it should be a shorter time frame. If the patient is,
No, page 4 of 4H. Not that I got the time frame of 7 days.
same
which
thing, I'm
was-
not clear on what if it's necessary to have something spelling this out. I mean, I think whether you're dealing with something as a telehealth or in person, everybody's procedures should be the same on how to handle an emergency situation. I'm just trying to alleviate
Well,
having,
they should be the same. However, as we've seen in enforcement cases, that even though our emergency procedures, our referral procedures should be the same within office, that is not the case in practicality. So ensuring that this is documented for the licensees, they understand what the requirements are. So I think that was the thought process. Ms. Walker, did you have anything to add to that?
Yes, I'll start with the protocol there at the end. It's a little bit, we made the distinction there because when you talk about your protocol for most patients with an in-office visit, the protocol is generally to call 911 if there's an emergency. It's a little bit more complex for a virtual care visit because you're not physically present with the person. That's why you see in the text they're having to figure out or identify the patient's location at the visit and then have the protocol and plan in place. There is language there requiring that that it be a written protocol, more so as if something was to go wrong and evidence-wise, we could request and review that protocol. Then the subsection E, the 7 calendar days, the committee kind of had a discussion one way or another on that number of calendar days, so that's probably fine. In response to the question about the verbal or written informed consent, that's required by statute. So we have to include that in there. And that language, we're just clarifying or specifying how a licensee goes about complying with that provision. So we're taking statute and making it more specific. But we can't delete it because it's required.
but is that specific for telehealth? That's the way it's written here. It says for the use of telehealth. It's not verbal or written consent for treatment.
It's required for, I just pulled up the statute. It is required for the use of the law specifically states before the delivery of healthcare via telehealth, the healthcare provider initiating the use of telehealth shall inform the patient about the use of telehealth and obtain verbal or written consent from the patient for the use of, So it's all very specific to the use of telehealth as an acceptable mode of delivering healthcare services in public health, and the consent shall be documented. So what we're taking that provision of the statute and making it more specific in how you comply, either through verbal or written consent.
Okay. So a patient going along with the telehealth visit would not be implied that it is a verbal consent. So we're just requiring that licensees document that there was verbal consent.
Correct. Yeah.
I'm just trying to play this out. With you getting an enforcement case, I would think that most practitioners would say, well, we completed a half an hour telehealth visit, so it was obviously verbal consent. So are we looking for that to be documented in writing?
Yes, because just like we see the same issue with any case involving informed consent. outside of virtual care, just standard informed consent is required to be verbal and written. And we get complaints all the time about from patients that say, I wasn't provided informed consent. And that's usually kind of the rebuttal that we'll get is like, well, they participated in the visit, but that doesn't mean informed consent. So the idea here is the language specifies how a licensee goes about documenting either the verbal or the written informed consent for participating in telehealth. And then it gives us a clear mechanism for enforcing it.
Okay, so we have that on our new patient forms. Maybe we can make a recommendation to practitioners right off the bat to make it easier for them. I'm just trying to minimize another layer of complexity for people that are doing this. We just have it on our forms right off the bat that if they elect to do so, we can deal with some calls via telehealth. And then how about the license number? Is it necessary for the individual to provide that license number proactively or upon request?
That kind of feeds into a prior or different regulation that the licensing committee already worked on when it came to providing notice of licensure. And the idea behind that was not putting consumers in the position of having to ask for things, and instead having the licensee be upfront and just provide the information that they should have. So this language kind of mirrors what the position that we're already trying to take on that issue when you're physically visiting a chiropractic office, or if you're getting treated in more of a mobile setting or some sort of temporary kind of pop-up. This adds on top of that. So we're kind of being consistent across the board. We don't have scenarios where under certain circumstances, the licensee has to proactively provide it, and then say in telehealth, you have to ask for it. That's the rationale behind it, is that you're always providing that information up front for the consumer and they don't have to request it.
Okay.
And again,
Thank
these
you.
are on initial visits. It takes 10 seconds to give your license to the patient. But again, it's making everything consistent across the board. And that way a patient who may not feel comfortable asking does not have to ask. That puts a huge load on the patient, and we never know what's going on with them, and they don't get the doctor's information, and then they're complaining to the board and they were uncomfortable. It was never presented. So it's a consistency of being transparent, which is consistent with the satellite certificates and the QR code, that the patient has immediate access without having to ask. We should not be putting the burden on the patient to ask for the doctor's license. And again, this is for the initial visit. And Ms. Walker, the section that we did talk about in our meeting that we're sort of missing is the subsequent visits. We talked about clarifying between an initial telehealth visit and then subsequent, so that it's not overly burdensome. And then you can see as attachment 3, we created a checklist for licensees to make it as simple as possible so that they understand what they need to have, and their protocols. They're not writing a protocol for every telehealth procedure. It's that they have a procedure in place. They're doing a Zoom call with a patient and something happens. Do they have a protocol for an emergency contact? They may have that information if they saw them in person, but if they never saw them in person, they didn't receive the appropriate paperwork. Where do they live? What's the emergency services next to them? There needs to be some thought into if there's an emergency because you are not with them. And it's not a protocol that they're having to write every single time. It's a basic office protocol of this is how we handle an emergency.
So how are we, I understand telehealth for follow-up visits is fairly easy, but for the initial, absent a history, how are we ensuring that the practitioner is compliant with all the other regs that we have as far as the physical examination and whatnot?
I don't understand the question.
how are we ensuring that the person is being examined if it's via telehealth? So are we allowing a provision to not have them examined? Because if they showed up in your office, you're not able to just take a history and jump into care. You have to do an appropriate examination on the individual. So I'm just not clear on what we're going to do with the scenario for initial visits that are telehealth.
Yeah, I still don't understand the question. I
Are
mean,
we
if
waiving
in
the
the
exam?
paperwork, you see that the doctor has to decide that the care via telehealth is appropriate, that they are competent. So they've already had to make this decision. And they are performing somewhat of an exam via telehealth. I mean, you have your observation skills, you can have the patient stand up. I mean, the same activities are happening, whether it's telehealth or in office. So I guess I'm not understanding what the question is.
I'll give you something very simple. So for instance, with blood pressure, we're not looking at vitals via telehealth. So are we going to make a provision that those are not necessary in a
Well,
telehealth scenario?
And that is a question because actually those vitals for telehealth are in medical telehealth visits. So they will send you a form and the patient is to fill out their blood pressure, their heart rate, their respiration. That is in the medical virtual telehealth paperwork prior to the visit. And so that is the conversation. Are we going to require that? Because that is required in other professions. Is the verbal okay? Is the patient reporting okay? Many people have a blood pressure cuff. Many people have a pulse ox already. Maybe people have their Apple Watch. But that information is obtained through a medical virtual visit before you even get to the visit. That is upon check-in.
So, but are we including that in here? That's my question.
That's a question for the board to discuss as far as, do we need a statement for that, or is that, and maybe this is for Ms. Walker, or is that already in our in office, and that because we're mirroring this from that, is that covered, or do we need to make a specific statement regarding that?
Just like to jump in and add that if you look at subsections, so the idea isn't in the regulation to to duplicate all of the existing regs as they relate to virtual care. It's to layer on top. So we're trying to specify the additional requirements that are specific to a virtual care visit. All of the same other standards of care obviously still apply. So looking on page 1 into page 2, that's where we do have that. We've specified in subsection C that they may provide virtual care subject to the conditions of this section. A licensee shall exercise the same professional standard of care when providing chiropractic services through virtual care as is required for in-person care or any other mode of service delivery, and shall comply with all of their provisions of the Act, board regulations, and other provisions of law. So that's kind of where that comes into play. And then as you get into subsection D, that's when the licensee has to make that determination, that they have the ability to conduct an appropriate evaluation through a telehealth visit. It's all going to depend on what kind of care the patient's seeking. If the patient's seeking certain things that can't be delivered through virtual care, the expectation is the licensee doesn't attempt to provide that type of service. But there's other types of visits where virtual care would be appropriate. If someone's seeking some sort of nutritional counseling, you can likely do a lot of that through a virtual visit. It wouldn't require an office visit. So that's kind of the idea there, and that's how it's written. We're not trying to duplicate all of the existing regulations and then specify them for virtual care. It's just layering on top. So happy to answer any more questions but I just want to clarify that.
If I might jump in, Chris, and I appreciate that overview there, because that's how I interpreted it, is that everything that applies to a in-person care is going to apply to the virtual care, but then you have to have certain things on top of that, which I think you spelled out pretty well. I guess I've often looked at this, getting back to like the informed consent aspect, is that you have to do the informed consent because of statute, but also, I think just like when people come into the office, I would say 90% of the time, the people that come in and make an appointment in your office, they intend to, they've kind of already made the decision, I'm going to start chiropractic care. But there are also those people. I mean, I've had people come in and we're in the middle of the consultation, and it's very clear that this person's just checking me out as much as allowing me to work, and so sometimes you determine that it's not a good fit, and it doesn't go anywhere, and then they go on to the next thing. And so I think, I think these we can't just make assumptions. We have to, spell things out and make sure that the individual that's in front of us, is interviewing us, and sometimes as much as we're interviewing them before we go forward. But we still have to have those the information in place so that if the visit ends, there's not any ambiguity about where people were located and what procedures need to take place. I mean, I just look at the standpoint of, like, if I'm in the middle of a consultation, I've had people that are like all of a sudden start feeling dizzy. If that's happening in my office, that's very different than if I'm in the middle of a telehealth conversation and I don't know where that person's located and they haven't told me and I haven't told them any. I mean, I could see how that would be a major problem for me and for them, because I can't then call somebody and say, here's where they're located. And if they're by themselves and they don't have someone in their house, I can't access emergency services on their behalf. So I think having all those things in front and up, in place before you start or within the first few, minutes of that conversation, so that where they are, they know who you are, they know where you are, makes sense to me anyway, as I read it. So
I think it all makes sense. I think we need to be careful and include something in there for vitals, because if we use the example Dr. Daniels was talking about, as far as somebody having some dizziness, we have practitioners that, are jumping in and assuming it's from somebody's neck and giving exercises or something of the sort, without this person maybe having some hypertension, maybe having a stroke, maybe having something of the sort that, if we're not requiring those basic things or making it easy for practitioners to obtain those basic things, we're going to see significant problems. And I'm just trying to avoid having any of the regulations that we're including here to get pieced apart by an attorney, and say, well, you included this, but you didn't include that. So, having somebody get off on a technicality. So I think having those forms that every other practitioner is required to have would be wise if we just maintain the same standard.
well,
So
and I
thank you.
think that's addressed in here, because it states, I mean, just like in your office, you have to have all that stuff as well. And I think that's what this says, is that all that still applies, and actually additional information applies. Because when someone's in your location, it's kind of tacit that they know where you are, or you know where they are. Whereas in a telehealth, I don't know that you're going to know that, right? You won't necessarily know that right off the bat. And their forms, could have been filled out 2 or 3 days before that, and then they could be in a different location. Someone fills out their forms, they live in San Francisco, but now they've traveled to Seattle. That, you got to know that. I mean, I've never done a telehealth consult, so I don't know, but I would think that I would definitely want to have all that information. So.
Any other comments, Mr. Sweet, Ms. Cruz, Dr. Paris?
Yes. Just wanted to put just my personal experience out there of when, in my experience of doing, of being on the patient side of a telehealth consult, what I personally experienced is a couple of things that we've already mentioned. So them asking for my location, asking if anyone's home, right, in case of emergency, so that they know, like they're aware. I've experienced having to fill out definitely forms ahead of time leading up to the appointment. And I've also have experienced When it comes to vitals, I gave what I could. I can't always find my blood pressure cuff or my, what's it called, oxygen reader. But they're there and available. So it's just real life examples of folks may have it, folks may not have it, but knowing that in some situations where vitals are not readily available, I've had providers ask me just kind of questions around it about how I felt in general to just get a feel. And so I'm not sure, I know it's not very specific procedural things, but at least in my real life examples of whether it be a help desk or a new doctor provider through telehealth, and or even a nurse appointment through telehealth. Those are actually the common things I've been seeing in each of those types of situations, whether it be phone or video. So just want to put it out there.
Thank you.
Well, thank you for that. That's insightful for me because I've not had that experience. I appreciate you sharing that.
Any other comments? We can circle back, or we can move on to the AI discussion.
Well, this is the regulation that you were looking for a motion on.
Well, I think
So
personally, I mean, we moved it to the board, you know, for that, but we did have questions. So, you know, we can see with Miss Walker and Miss Cruz as far as, I think it needs, you know, I was leaning towards 7 days, but I wanted the board's input. So we have some, I think, a little bit more cleanup and tidying. I feel like we've had a good discussion. So I personally wouldn't move this forward because I feel like what I would change are slightly more substantive, but Ms. Walker can agree or disagree on that. And then Ms. Cruz, you know, please let me know your thoughts on doing just a little bit more work and bringing it back in October. We felt like it was close, but we had some questions.
Yeah.
We've gotten the feedback that we wanted, and then we can clean it up a bit more.
Well, I'd like to put a little bit more if I can, because I think it'd be good. So I concur with Dr. Azzolino. I think closer to 7 days. I mean, in an emergency situation, I could even see a case for 3 to 5 days. When in this emergency situation, you would think that you're going to probably be following up with that person pretty quick. I think a week is probably acceptable, but I mean, I could make a case for it to even be shorter when we're talking about an emergency. And I mean, the definition of emergency can be nebulous, but when I think of emergency, I think of an emergent care situation. That's somewhere where somebody feels like they need something right away. So I could make,
I mean, I think the thought behind it was that within that time period, the doctor, the licensee needs to have provided the informed consent, a summary of what happened. Obviously, we're hoping that the doctor would follow up sooner, right? You know, the next day. But what is required is that they have to follow through with the actual paperwork, with a written summary, so that they can read it, their caregiver can read it, you know, they have a hard copy of it. That was sort of the thought, not that we're waiting 7 days for the doctor to follow up. It was something reasonable
to get all that wrapped up.
Yeah, I mean, say the doctor's on vacation, but you know, they did an emergent care. They have a few days to kind of dot the I's, cross the T's, get that information to the patient, hard copy. But obviously, we would expect them to reach out before that. And, you know, does that need to be put in there? I don't know. But that was the thought behind the time delay, as far as making it operationally feasible.
In light of that, I think the 7 day makes sense because that gives you time. Obviously, you would probably be following up sooner, but to get all the paperwork and all the documentation in line, 7 days would be, I think, and certainly a doctor can have a verbal conversation with a practitioner that the emergent person may end up going to and then the documentation to follow. So also, Dr. Azzolino, having had the conversation, would you say that is there some specific things to specific sections that you would give to the committee that would help them, or having had the discussion, is the language make more sense to you now that you could be comfortable with it?
It makes sense, but once again, my overall goal is always to not have our language so different than what all other healthcare providers are bound by, because I think we could get ourselves in trouble legally if we have different regulations that have little nuances in between, because it gives attorneys the ability to cut the lines. So I would say we adopt what's generally accepted out there in healthcare, which I believe everybody agrees with. And we just have some small provisions, whether it's the 7-day or the 14-day. But I have another question just off on this. Are you aware of how many people are actually doing this here, Kristen? Having initials? I mean, I have them for follow-ups to see how somebody's doing, but possibly for a history, but certainly not for an examination on an initial case. So are you aware of how many people are actually engaging in this activity for an initial exam?
I don't have any specific data on that handy for this meeting. I'm happy to report back to the board with what we may. I'd have to evaluate at the national level and see what we may have captured when we did our most recent occupational analysis at the state level.
Yeah, it'd be interesting. I think that's a question that we should, in this day and age, modernize our questionnaire and make sure we're capturing how many people are actually engaged in this activity so we could serve people at the highest level. Because I'm a little concerned with people doing initial evaluations and having it go more than a visit or two if they're not getting their hands on them and examining them or getting them over to somebody that does. So yeah, I don't have any further comments. I think just the HIPAA compliant thing, back to what you were asking for, that I think Dr. Daniels noted, the HIPAA compliance and the days, but I'm good with everything else.
Okay. Dr. Daniels, having heard that, do you feel like the changes would be substantive enough that we need to delay it and push it to the next meeting, or do you feel like you can entertain a motion?
No, I feel like it's enough that we should delay it, but I think we can have it ready for the next meeting. And we don't have numbers on how many people are doing initial telehealth. I'm not even sure we can get that because not everyone discloses it, but we can look at the occupational analysis. Just in, my conversations with people, it's prominent and it's happening more. And much of what is in here is based on what other healthcare professions are having as their telehealth virtual care regulation. It is in line with that. It needs to be cleaned up a little bit more. And as we move forward, anyways, it's happening. I think it's happening more regardless if we personally feel that they should have a physical exam in office. Other people are doing it, don't feel that way. So we do need to kind of create a safety net to address that.
Okay. Well, I think we've had a good discussion. I think we've got some good information. So with that, if there's no other comments from the board on the virtual telehealth aspects, I think it'd be good to move to your report on the AI
Okay, sounds
discussion.
good. So the AI, discussion is, and the language that's in there, this is just the draft is not where we want it. We're still working on it. The draft that we previously had was really more, let me just find my notes, make sure. Anyways, we've mirrored or the discussions have been around the executive summary from the Federation of State Medical Boards on navigating the responsible and ethical incorporation of artificial intelligence into clinical practice. And so the committee's conversations have been based on that executive summary and the conversation. And again, it's trying to create broadly specific safeguards for the public. And the language for this is a bit challenging because we need to try to future-proof the language. And so if you look on an example, say page 1 of 4, under B, it says standards for use of AI or Gen AI, and the next paragraph under 1, to try and future-proof the language a bit more, we've changed it to, as an example, to any automated computational, algorithmic, or technology-assisted system, because we really don't know what's coming. We don't know what it's going to be called. And so this package is a little challenging. How do we protect patients now, yet sort of future-proof the language? So as you go through the document, we didn't clean up. I was going to ask Ms. Walker, we didn't clean up. It says AI or Gen AI in many of the places, but it should be that broader statement, or we need to define that broader statement and sort of refer back and have, you know, an easier reference point. We were leaning towards a, you know, and some people aren't going to like this, but a separate AI consent form, with also giving licensees sort of a checklist of what that involves. There are conversations in the literature about patients receiving access to AI, not being biased, being able to remove their consent in the process of. And so we were really trying to touch on the points of, similar to kind of the idea of the Belmont report, autonomy and fair treatment, etc. So you have the document in front of you. We're open to the conversation. This is a little more of a rough draft, but we did want to bring it to the board so we can get some feedback, because as we move through these, we like to work with legal and work with the board. And so they're getting cleaned up as we go. So once it's done, it's done.
Well, my comment would be this is a great start, and I think it's a great framework. And I also see the, you know, the potential here that, you know, it's ever changing. It seems like, you know, if you know, 1 minute you think one thing, and then it just keeps getting more advanced. And I mean, I just recently, you know, saw in the news that they, you know, that they had created some sort of
AI got out
AI
of the
thing, and it
sandbox.
ended up hacking its way out. You know, I mean, it's like, you know, it's kind of like the genie, it's like Pandora's box here. So, I mean, I think, you know, this is a great framework, a great start. It's coming, it's here. People are using it. It's pretty amazing. I've used some of it. I've not used it in relationship to practice, but I have used it in other aspects, and I can see that it can be a very powerful tool for efficiencies. My concern is, I think, the same as those on this board, and that is that I would hate for practitioners to start using this as their diagnostician and take away their importance of knowing their information and knowing what's sitting in front of them when they see it, and not, you know, thinking that, you know, some agentic, you know, machine is gonna take the place of them being able to be thoughtful and to be well on top of your skill set and your observation skills. These machines are really as good as the person that's inputting the information. And if people are relying upon it and not making good observation and having the skill set, then I think mistakes can be made. So
So this draft of the regulation really puts the responsibility, clarifies the responsibility onto the licensee for every decision
wholeheartedly
that is made, and that the informed consent is just not just a list, but it has to be an active conversation. And that there's disclosures if a patient decides to withdraw, that, you know, there is no discrimination, there's no bias. And we did put in there a written, a referral, and we put if available, because we understand that that is not always available, but that an attempt by a licensee to get that person to where they need to be. And then also trying to future-proof it for the licensees. There is some conversation in the literature about AI becoming a standard of care. And so we put that clause in there specifically that this is not the standard of care. So if we have a licensee in a rural area, that they are not being penalized under the standard of care because they don't have all this money to buy, you know, AI. So we've put that clause in there to have that conversation about of what's coming and what is going to be considered standard of care. And that's a little bit up in the air as far as if that is going to shift. So the way it's written right now is to put the ultimate responsibility on the licensee, that they must have a well-informed consent, and that there is no discrimination and coercion or different treatment. But at the same time, that the patient is informed that if the addition of AI would benefit their care, they need to also be told that. Again, it goes back to the idea of the Belmont report: autonomy, beneficence, and justice. And that's that in combination with the Federation of Medical Boards executive summary was the backdrop to what we have here. Again, it's not finished. We really want some feedback and comments and conversation so we can get it moving.
Well said. Any other comments from the board?
I'm hoping, can we clarify? I'm looking for the language, and I might just be missing it, that kind of supports the ability to utilize the AI to the patient's benefit, and that, you know, that's done in conversation, and so because it's likely to have a potentially positive impact.
Yeah, that's
And
what
that
I just
includes
mentioned, and I
even
believe
the
it's in
clinical.
there.
Yeah, where can I get pointed to that? I'm reading through it. I must be missing it.
And maybe in our conversation, Ms. Walker, with the informed consent, we didn't include that. Because I know that was part, Dr. Paris, I know that was part of our informed consent of stating the benefits so that the person can make a decision.
And just requiring that discussion happen, that
Yeah,
this
that's
was
in the
AI
informed consent
recommendation.
section, which we don't have.
I remember reading that in here. There's something that gives benefit. There's something in here I remember reading that I just can't remember where it's at.
Just to clarify, subsection B authorizes the licensee to use AI in chiropractic practice just broadly, subject to the conditions of this section. And then subsection D2 is where it's talking about informed consent, and it requires written explanation in clear language of the potential benefits, then also the risks and limitations of AI, which will broaden up that language. So those two kind of work together there to meet that need.
And we did lead with benefits versus leading with risks and limitations. I mean, that language was put in sequence for a reason, to sort of emphasize that there's benefits, but there's also risks and limitations.
I see all that. Thank you. I mean, you know, because it can be framed as having a really nice, comprehensive second opinion in the room with you. Mm-hmm. So I think there's a lot of positive there. So yeah, thanks.
Again, the board's, like, the way the committee viewed it is the board's responsibility is not to dictate what a licensee uses as far as the technology, but it is to maintain an ethical standard that is similar to other informed consent and, you know, manipulation, et cetera, that those standards are the same and that the licensee is not being penalized, and unless it becomes a standard of care, and that is what is required, and that the patient is not being penalized because they have fear about their information and AI. And, you know, we have many patients that perhaps are going to be very uncomfortable for maybe particular health reasons that are not going to be okay with the use of that. And so we viewed it as protecting the patient, not being discriminated against or treated differently.
Any other comments or questions of Dr. Daniels or Ms. Cruz?
So, I mean, I guess I have a question. So where the committee was leaning was, you know, this is cumbersome, but we did feel that this is needed. When, you know, I'll go to a doctor's visit and they'll say, you know, are you okay with a scribe? Well, I'm like 100 years old. What do I think of a scribe? I think of a person, right? So they're not giving me informed consent. They're not giving me true informed consent. They don't sit me down and they don't go through, this is what we're doing with your information. This is how it's used. They're not saying if this is being used in their diagnosis or their treatment. And so there is a gap as far as patients having informed consent. And this is a burden, I think, for the licensees. However, the committee feels that this needs to be looked at as, is this a reasonable burden that the licensees must take on? Is a separate informed consent when it comes to AI technologies. And so before we do any more work on it, I would like feedback from the board as far as their thoughts on what that means. And if, again, we really kind of looked into the literature and based it on the Federation of Medical Boards conversation. And so that really put it for us in the category that there needs to be a separate AI consent. It's just too much to put under the current. And then if we have to change it because it's changing, we don't have that ease of flexibility of changing that. But really, it was more about patient protection. So what are the board's thoughts on requiring a separate AI consent form that goes through kind of all the checkpoints as far as the risks, the limitations, and having that full conversation so that that patient can make the appropriate choice for them?
I think there's an oversimplification if we're looking at AI for a scribe and AI for diagnostics. So I think we almost would have to have two, because I would never use AI for diagnostics, but it certainly can be very good for a scribe. And if we just put that all into one package, we may have people that object to AI because they think it's in an open platform where their data is being shared versus just a simple program that's a dictation program. So if we're going to require a form, I think we should probably require two, one that's for the simple aspect of dictation and transcription versus AI for diagnostics, or one that has a checkbox for either.
Okay. Dr. Paris, Dr. Adams, Ms. Cruz.
I think that's reasonable, because I think, you know, that's one of my things that I've had questions about is, you know, is it a closed system where the information is staying within, you know, a kind of a HIPAA compliant vault, for lack of a better term, whereas, is that information being utilized across? I mean, I see the value in that if you have this collective of all these individuals across the country, across the world that are having conversations, and a lot of similarities come through, you can see the benefit of having that information being able to be utilized by the agentic system. But at the same time, what can get out, what can be parsed out, from an individual's health issues. And that's one of my big questions about AI in general. And I don't know that, I mean, every time I talk with somebody at a seminar and ask them, is their system closed? They're like, oh yeah, our system's closed. Well, then how big is your database and where are you drawing from? Because I would want, if I would want more, but I also want it protected. So I don't know if I can, if that's possible, if that's going to be part of this, but I see the value in having the dual approach, because if you're just using it as a scribe, so that then you can detail the conversation and then utilize information that you get from that in making an evaluation and diagnostic aspects without running that through a system. I see that as two different things.
Yeah,
I agree.
that
I agree
aligns
with
with Bonta's bill as far as separating out the scribe versus technologies.
Yeah, I concur with that.
And furthermore, I think it comes right back down to the same thing. The responsibility needs to be maintained, that everything needs to be HIPAA compliant. Where we run into trouble is there's practitioners that want to go on the cheap for everything, and they just try to use platforms, whether it's Zoom, whether it's a Scribe or something that does not have HIPAA compliance. So any appropriate software in healthcare will have HIPAA compliance. And I think it's, the burden should be on the practitioner to make sure they're getting the appropriate system in that regard.
I concur.
Yeah, my only suggestion might be just for ease and of our licensees, and to hopefully decrease some confusion looking forward. I think it definitely, we need a separate AI consent form. And then I don't know if that has the ability to be somewhat educational and listing the potential uses and then what that specific office is using it for, versus having multiple forms, based on if you're just doing a scribe, or if, if you're generating notes, or if you're using it to help make treatment recommendations. I would just like to see us kind of limit the number of potential forms that could be used out there. I see that as a big source of confusion into the future, but I also see the opportunity to have and even if we had to draft some suggested language or something, but as an opportunity, understanding too that AI may change, but as an educational opportunity for, I don't see patients really fully maybe comprehending the different uses unless we at least lay out some basic language as an educational opportunity for them in the interest of public safety. But I would like to see that at least maybe discussed and looked at as potential to have one form for that with just some differentials. That's
Great.
all. Thanks.
Thank you. Yeah, and we did talk about kind of creating a form for licensees, as far as the consent, which we can't do, but we can do the suggested language like we did in the checklist for the virtual care, because one of our goals is to try and increase the transparency for the licensees from the regulation to their day-to-day, and make it clearer and more simple for them so that they are complying and they do understand how to take the regulation and make it, as far as their office procedures.
Dr.
Okay.
Harris, did you say something? Okay. Oh, no.
Okay, great. All right, Dr. Daniels, do you need anything else? You've got You've got a great report here. I think this is a phenomenal start on these two categories, and thank you so much for your heavy lifting. Is there anything else that you feel like you need to get?
No, I don't think so. But as I've said before, if things come up between meetings, please just shoot me an email. So, because we're constantly working on them so that we can get them moving forward. Just let me know.
And Ms. Cruz, do you have anything you'd like to add to the licensing committee report?
No, just that I would incredibly appreciate the leadership of Dr. Daniels in this committee. What's it called? I personally come with just my personal experience and just general kind of business background, but I definitely want to kind of give kind of all the flowers to Dr. Daniels, and I would say the amount of insight and the amount of research and kind of intentionality that she's brought to especially this package. So
Thank you. Well, thank you for being there and supporting her and giving your input. It's all valuable. Appreciate it.
Yeah, definitely need you there.
Okay, so we won't be entertaining a motion. If there's no other additional comments, I would like to move to public comment. Then following public comment, I think we should take a bio break and allow people to get up, stretch a little bit, and then we'll come back and then take this to the finish line. So with that, if you would, moderator, please open us for public comment.
Hi, this is the moderator. If you would like to make a comment on this report, you may look for the raise hand icon at the bottom of your WebEx screen or next to your name. We are displaying instructions and we'll give you a moment. Any raised hands or comments, I turn the floor back to you, Chair Adams.
Okay, is everybody okay with a quick bio break, or because I think if we do that here, then we can take this right on to the end and get finished up.
Sounds good.
And then I know I've said 5 minutes in the past, but somebody tells me that I have to do more. So let me know, Kristen, what we can do that follows the legal aspect of giving people plenty of time.
Oh, go ahead. Sorry.
Or Miss Jacob, I guess.
but yeah, I don't think that there is a set time. So maybe let's give maybe 10 minutes.
Okay. Then let's go 10 minutes and we'll see everybody back here at 10:57. Okay, I have 10:57. Do we have most of us back?
We are waiting for Jeanette still.
Okay. Well, she's going to take the quick roll, so. I think according to the rules of decorum, we need to, after a break, take a quick roll.
Oh, I'm back. Sorry about that.
All right. So Jeanette, if you would just take a quick roll of the members of the board so we can all attest that we are present.
All right. Dr. Adams,
Yes.
Dr. Daniels,
Present, same address, 1165 Park Avenue, San Jose, and no public members are present.
And I'm still at 101 Andrick Street, Sonoma, California. No public members present.
Ms. Cruz, I am at 1625 North Boulevard, Suite 220, Sacramento, California, 95834. No members of the public present. Dr. Azzolino. We'll come back. Dr. Harris?
Present 3455 Knighton Road, Reading, California. No members of the public present.
Mr. Sweet?
Yes, present 4100 West Alameda Avenue, third floor, Burbank, California, 91505, and no members of the public are present.
And given Dr. Aslino is not back, we do have a quorum, so we can move forward.
Okay. We are on agenda item 10. And I will turn the time over to Ms. Walker.
Thank you. So just briefly, we've got under agenda item number 10, we're returning the continuing education regulation language back to the board with some recommended edits. The meeting materials outline 25 of them. I won't go through every single one of them point by point, but I do want to highlight a few of them. So if you look at the meeting materials number 6, there's a proposal there that we narrow the list of other professions, continuing education that we would accept. Staff took an initial stab at that list, so you can see where we've listed the professions that would be approved or accepted, and then the ones that would be removed. Like to entertain a board discussion on that, and if you'd like to see any of those move from one column to another. So we'll just want to have a discussion there. Item number 7 came from some stakeholder feedback and discussions that Dr. Adams had with a potential recommendation to delete competency 3, adjustment, manipulation, and technique from the list of competencies that requires a synchronous learning method. So a little discussion, entertain a discussion from the board on that item. When you get down to number 10 on the meeting materials, there's a recommendation that we remove the prior distinction between board-approved CE providers and those that are recognized through PACE. The rationale there is when we were working on the sunset bill and our fees and everything that would go into the continuing education program, one of the problems was that our CE providers, their biennial renewal fee wasn't covering for the general maintenance and operations of that program. Seeing as how we're now transitioning the providers into the Connect system in the fall and heading into next year, we reformulated that CE provider renewal fee and the application fee to basically cover our overhead costs for administering basically that functionality. So the idea is that we realign that language and make all providers go through the board approval process and pay their kind of fair share of those fees. So that's a recommendation coming out of that. Going into also number 14 in the background materials. So with kind of changing that, so the prior language would have basically let a PACE provider go directly to the board and apply for courses. That doesn't quite work under this model of the way the Connect platform is designed, and then also, like I was talking about, paying for those costs. So instead, the idea is to kind of realign everybody, and all providers have to go through an approval, but those that are recognized by PACE would basically be qualified for like a fast track, where the board could grant authority to the executive officer to approve their application rather than having them wait for the next quarterly board meeting, with the rationale that they've already been vetted through the FCLB PACE program. So they could apply to the board and get practically immediately approved rather than having to wait for the next quarterly meeting. Also important to note there that the language we put there was around may, not shall. So there's still discretion there that if there's something potentially problematic in the application, it could still be brought forward to the full board at the quarterly meeting, not automatically approved. So there's that language. Under item number 15, deleting the word biennial when it relates to the CE provider renewal. So the statute currently establishes a biennial fee. Our sunset bill deletes that word. So our recommendation is to make the CE provider process annual so that we can better fund that program and our overhead costs for the Connect platform. as it relates to CE functionality. Then when you get into number 17 and 18, this also comes out of our sunset bill. So it requires that we establish a delinquency fee for a CE provider renewal status. So we've done that, and then also basically creating a late renewal process. Right now, if you fail to renew by your expiration date, that very next day you're immediately canceled and you have to go through the full approval process. We're proposing giving a 6-month window where after you and then after 180 days, that's
Kristen,
when, go ahead.
Kristen, you're going to
Yeah.
need to back up about 10 seconds because your voice dropped out.
Oh, okay. Okay. Did you hear the explanation of the annual CE provider renewal?
Yeah, it was just after that. You just
Just
dropped
after
off
that?
for about, yeah, just a few seconds.
Okay, thank you. So after that one, it's getting into number 17 and 18 on the background, on the meeting materials, has to do with establishing a process for late renewal of a CE provider status with a 180-day window. So right now, under our current regulation, if you fail to renew, the very next day you're canceled and you have to go through the reapproval process again. Under this proposal, you would have a 6-month window where you can apply and you basically pay the renewal fee plus a late fee and you can get back in. So there's that language. And then finally, number 20, and the board's had a little bit of discussion about this, and it related to our fees and how we were going to structure the program. We had originally written the regulations to provide a 3-year approval window for a CE course. We're recommending that we revert back to the status quo and just maintain the annual renewal period. So like I said, there's 25 changes in total. I'm really looking for the board's feedback specifically on a few of those items. And then within the language itself, all of the changes that have made since the board last approved it are highlighted in yellow. And with that, I turn it back over to the board for a discussion, and I'm happy to answer any questions.
Thank you. The only one that I have on number 6 is midwife. We have a number of licensees that are doulas in the state of California. And so I think having midwife under an approved, accepted healing arts board makes sense.
I need some clarification on this, Kristen, because I was actually going in the other direction from Dr. Adams there and was thinking we should remove acupuncturists. I was thinking everybody in the approved should have a quasi similar scope or responsibility with their license, but can you please enlighten me a little on this, what this list means?
Yes, so the board's current regulation accepts CE from any DCA Healing Arts Board. We took a list of all of the different professions and then we tried to separate them into what the board could potentially accept and then the ones that should be removed from the list. When we were coming up with the initial list of removed, we were looking at professions that are not closely tied to chiropractic. And then we also identified ones that are more at like technician level rather than direct access primary provider type status. That's how we came up with that initial list. Acupuncturist was included because there's direct access to them. But again, we're going to defer largely to the board on what you want that final list to look like.
I just think the nature of what they're doing in their continuing ed is very minimally applicable to us. And I would say the same with the midwives there, Dr. Lawrence, but I'm all ears here. Vets is another thing that I would yes, if you're certified to take care of animals, otherwise probably not too applicable. And then I would just make sure that we include all primary providers. Physicians and surgeons should imply osteopaths also, but we may want to put that in there as separate, doctors of osteopathy, and then other primary providers are the nurse practitioners in California also.
Well, my reasoning behind moving midwifery over to the approved section is that if somebody is a chiropractor and they're taking some continuing education in their area of expertise as a doula, that could count towards their continuing education in the elective section. These are more related to the elective portion of the competencies, not to the core competencies of chiropractic. That was my reasoning. I mean, I'm open to pare down the list. I'm just, I thought it was good in a sense that people can, if there's a dentist out there that's say talking about TMJ stuff, I think that could be applicable in the elective section. So those are some reasons optometry, same type of thing. I mean, looking at the eyes, understanding things about the eyes, I think that's all can be helpful under the elective section of continuing education.
And kind of jumping off of what Dr. Adams is saying, I just even thinking about acupuncturists when it comes to a patient in pain, a patient having nerve pain, right there, right? It may not be one for one, but going back to the fact that this is specifically electives, right? Not core courses. I see an opportunity to leave that there, but just want to put it out.
I would support acupuncture just as a doctoral level portal of entry, healthcare practice, but also, they do have actual manipulation in their scope of practice, and I believe it's called Tuina, and it's part of their curriculum. And so I think there may be I know that there's some overlap potentially in the continuing education opportunities, maybe not with the core intervention, but I think most of the other healthcare providers on that list at the doctoral portal of entry level also have kind of more oblique, overlap in the scopes of practice, including physical therapy, et cetera, where, they are providing, manual therapy or manipulation. And I know for acupuncture, that is in their scope of practice. So regarding the midwifery, I have some concerns about that, as it seems really counterintuitive to me to support particularly that CE in our just looking at it from the chiropractic CE perspective, because I think 302B clearly has a prohibition against us as chiropractors, with our DC license, delivering a baby, practicing obstetrics. And I don't know. I'm having this dissonance when we then are going to allow for that particular CE, and I don't know what the hours are, but I know it's not necessarily a doctoral level program. So those are my thoughts. Thank you.
I'm in support of the nurse practitioner being added to the approved list. I think because they're becoming a primary portal of entry in California. Any other comments about number 6 or other aspects that Ms. Walker brought up?
Yeah, I'm in favor of adding osteopaths, nurse practitioners, and I'm in favor of keeping acupuncturists. not only for what Dr. Paris said, but also, there's acupressure points, there's needleless acupuncture with a device called a Teishin, which has to do with pain modulation. And so I think there is a bit of a crossover there, and it's an elective. It's not the, primary requirements as far as exam, etc. And I'm not completely in favor of the midwife. I kind of see both sides, but it makes me a little uncomfortable based on kind of what our statute says, and it makes it a little blurry for me, and I just would like to avoid any issues with that. So those are my thoughts.
Any other comments, suggestions? Okay, so are Ms. Walker, would these be substantive changes that we've suggested, or is keeping midwife where it's at and then adding nurse practitioner and specifying doctors of osteopathy? Would those be considered substantive?
We can work them into the motion. I do want to clarify that both types of physicians and surgeons are already accounted for in the language. So we've got those approved through the medical board and the osteopathic medical board. So they're already there. We would have to add language for a nurse practitioner to the list, which we can work into the board's ultimate motion on the language. So it is a substantive change, but we can address it through just specifying that in the motion.
And we may need to clarify that it's a nurse practitioner that has acquired the requisite hours to be considered. I think the nurse practitioners have to have a certain number of hours before they're considered to have direct access. So we might want to put that in the language that the nurse practitioner that we're referring to is, and I don't know if that's necessary or not.
It's not correct, unfortunately.
What's that?
It's not correct. They have their primary, if they're licensed in California, they are primary. And you're talking about whether they require physician supervision or not, but that's not substantive to the continuing education.
Okay, fair enough. So I'm in favor of that. So that's the one add that you would give to that. Any other suggestions on the board, or so adding nurse practitioner since osteopathy is already included? Hearing none. So Ms. Walker, it sounds like
I have one other comment, if I may.
Yeah.
So this is just clarity for me. Does the nursing board differentiate continuing education levels between like RN level CE and NP level CE? In other words, is it advertised that way? And how would we identify general nursing approval continuing education versus that nursing CE approval for at the level of the nurse practitioner? I've not seen it advertised that way or separated out that way.
If you're dealing with a furnishing license, there is a difference, but even at the level of the RN, I think their education for continuing ed is very equivalent to what many of our providers are providing in chiropractic. So I don't think we need to really distinguish that if we're only dealing with an elective level.
Yeah, the only reason I ask is that the RNs are in the removed category, and we're talking about bringing the NPs into the accepted, approved.
Sure, understood.
I hear yeah. Yeah, I think that how would we, yeah.
I mean, we could leave it out. We could move it over. I don't think it's a huge issue, but I think that's if we're just looking at all primary care providers, I think would be wise to just go across the board on all primary entry level providers.
Well, I think that's the distinction because an RN is distinct from a nurse practitioner. But you're saying that their education would be comparable.
Well, no, I'm saying if the whole idea is here, somebody may want to take a course in that, or if we have an acupuncturist that is a chiropractor and we're just having those elective courses, we should add that leeway also. So yes, there are a lot of courses that are not specific for NPs, but when you get into medications and whatnot, for instance, with a pharmacist and an NP, I mean, what are we hoping to achieve with taking a pharmacist's continuing ed versus an NP? It gets down into the same thing if you're looking at furnishing licenses and medications and whatnot. So I'm making the broad distinction of if they're a primary care provider, we should allow them the leeway to take those courses also.
So you would be in favor of adding registered nurse and nurse practitioner to the approved side?
That's why I was not clear on this. Are we saying that we have a chiropractor that may want to take a dental course? Or are we saying that we have a chiropractor that's also licensed as a dentist that we're going to allow some of those courses to come over? Are we just saying we have a
Well, it
chiropractor
would
that wants to
be
take an acupuncturist course?
it would be both in that sense. But the idea behind it is that if like let's say, I mean, as Dave pointed out, what if there's a chiropractor that, that we're authorized to do manipulation. They want to take an acupuncture course and learn about the acupuncture manipulation aspects and see if that, if that's something. Or in the case of a dentist that works with TMJ, a chiropractor that, maybe does a lot of TMJ work in their practice wants to take that course from that particular orofacial dentist.
Yeah, that
That
all makes
specializes
sense.
in that.
I get all that.
Yeah.
I get all that. There
So it's
are
going to
some
be both.
nuances.
I mean, I don't know that we have too many dentist chiropractors, but I know we do have a lot of acupuncturist chiropractors.
Yes.
So
So, I'm fine leaving that to Kristen to figure out if it's worth making that shift or not. But just looking at even the courses of a psychologist, yeah, I think it's very valuable to do that. Right back to the vet, I think it'd be great to learn more about animal care if you're certified. But my concern is with that, it blurs the line also if especially this issue that we're dealing with right now with chiropractors, being under the gun for taking care of animals. So yeah, Christian, you feel comfortable looking in this and making a decision on that, or do you need anything from the board?
Um, well, I'm presenting language for approval, so I would like the board to include which professions you want to include or exclude. If we have to make any changes to the language in the motion today. When it comes to, so the rationale behind like veterinarian is just, and it's similar to the other professions, is more around, Dr. Paris has talked about it during previous meetings as well, but like self-interest type coursework where you could just expand and learn from other types of providers. Veterinarians are of course direct access. That's why they were included on that list. As far as the discussion on nurse practitioner versus registered nurse, even though the continuing education requirements currently seem to overlap a little bit, my recommendation would be just to specify nurse practitioner, because then it would allow it to evolve over time. So if, say, the Board of Registered Nursing started actually differentiating between the two, we've picked the direct access provider and we didn't peg it to registered nurse. So that's just my recommendation, is to keep it narrow. The way this language is written, it puts the onus on the licensee to prove to us that it's accepted through these programs. So it's not like it's a very burdensome on staff to try to track down whether it's accepted for these professions. So that's kind of my 2 cents on it. I definitely was hearing nurse practitioner for us to add, so we could just incorporate that into a motion if this language is going to move forward.
you okay with that, Dr. Aslino?
I'm good with it either way.
Okay. All right. Well, then let's, if there's no other comment, then let's
And
allow,
are we leaving the midwifery out, or what are we doing there?
yeah, I'm okay with that. I'm not married to it. It was just that there, kind of along the lines of doulas are direct access. There's doulas that do that directly, and there are chiropractors that are doulas, kind of the same. I just was thinking along the same lines as the fact that we have chiropractors that are acupuncturists. But I understand the concern over, the fact that we are not, as part of our chiropractic license. I was thinking along the lines of somebody that's a certified doula, that's what they do in addition to their chiropractic. That was my thought. But I'm okay either way. If the majority of the board is not comfortable with adding it, then I say that we leave it out.
So Kristen, if we were to use the suggested motion, but we're going to add nurse practitioner, where do we add that into that suggested motion?
Let me see. I'm navigating to it right
it's
now,
on
and then
the-
we've also got a regulatory counsel kind of there to assist us. But we would want to we need to incorporate a change to just a second. I'm scrolling to it right here. We want to incorporate a change to section 361, subsection. A lot of numbers here. D8 to include continuing education that's accepted by the Board of Registered Nursing for renewal of a nurse practitioner license pursuant to, and staff will insert the appropriate chapter of the Business and Professions Code. So we need to make that amendment there to that subsection. And let me look at the full flow of the recommended motion to figure out where we would drop that in there. You would insert it. So with the suggested motion, where it talks about rescinding the prior approval, with the exception of the text for 365, because we're running that as a separate proposal, then to approve the newly proposed text, to amend, and then all those sections, and we would insert it there after where we talk about that. So if we're there, I'm happy to read it, but that's where it would drop in. It's kind of right in the middle of that motion.
I was just going to say, so if there's no other comments from the board, is there? Okay. So what I'm going to suggest, Kristen, if you can, like we've done in the past, if you can read the suggested motion, then one of us on the board can say so moved, so we get the language right, and then we'll get a second, and then we'll go to public comment and then vote. Is that acceptable to our council as well as Ms. Walker?
That works for me. Did the board have any other concerns or questions or comments on any of the other changes before we go to a motion?
Well, that's what I just asked for. And I wasn't hearing any, so I think if you're ready to do the motion and you have the way that you want to fit that in, that would be great.
Okay, sure. So the suggested or the motion would be for the board to rescind the prior approval of the proposed regulatory text from April 17th, 2025, with the exception of the proposed regulatory text to amend California Code of Regulations, Title 16, Section 365, and then for the board to approve the newly proposed regulatory text to amend California Code of Regulations, Title 16, Sections 360, 361, 362, 363, and 364, and adopt Section 361 or 360.1 presented in the attachment to agenda item 10 in the meeting materials, with an edit to the language to Section 361 subsection D8 to include coursework that is accepted by the Board of Registered Nursing for renewal of a nurse practitioner license, and then to direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business and Consumer Services Agency for review. And if no adverse comments are received, authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any non-substantive changes to the package, and set the matter for a hearing if requested. If no adverse comments are received during the 45-day comment period and no hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulations at CCR Title 16, Sections 360, 360.1, 361, 362, 363, and 364 as noticed.
So moved. Oh, okay. Dr. Daniels, so moved. And do I have a second?
Second.
Second.
Okay. We'll give this one to Dr. Paris. How's that? Seconded by Dr. Paris. Okay. Moderator, if you would open up for public comment on agenda item number 10, please.
Hi, this is the moderator. If you would like to make a comment on this motion or agenda item 10, you may look for the raise hand icon at the bottom of your WebEx screen. We are displaying instructions and we'll give you a moment. We have no raised hands or comments on WebEx at this moment. I return the floor back to you, Chair Adams.
Thank you. Miss Cruz, would you take the roll?
Dr. Adams,
Yes.
Dr. Daniels,
Yes.
Ms. Cruz, yes. Dr. Azzolino,
Yes.
Dr. Paris,
Yes.
Mr. Sweet,
Yes.
motion passes.
Okay. Thank you, everyone. All right. We will now move to agenda item 11. Update, discussion, possible action on the board sunset bill, Assembly Bill AB 2775, Committee on Business and Professions. Ms. Walker.
Sure, thank you. So the board's sunset bill was last amended on June 30th, and it now includes everything that the board asked for through the sunset review process, with the exception of the automatic chaperone requirement for licensees that are facing either criminal or administrative charges involving sexual misconduct. We'll continue to work on that issue offline. I've got a few other ideas that could get the same effect, but maybe more amenable to committee staff. And then I'm also interested to know if there's other DCA healing arts programs that might be interested in kind of pursuing similar authority. So we're going to take that issue separate from obviously this sunset bill, and we'll work on it, maybe in the next session or definitely by our next sunset review. But with that being said, happy to report that everything else has been included in our sunset bill. Importantly, it includes a new fee schedule that'll automatically become effective January 1 of 2027 through statute. So just like we did in 2023, we don't need to implement regulations for the new fees to go into effect. The statute carries them for us, which is very helpful for us. It keeps our workload down and allows us to make those changes in a much streamlined way. The bill also requires that we would be setting penalty fees for late renewals of satellite office certificates and corporation registration certificates. So we'll be working with the licensing committee to draft regulations to implement those delinquent or penalty fees. It also includes authorization for the board to create the temporary license to practice chiropractic for individuals who don't meet all of the board's specific requirements for a unrestricted doctor of chiropractic license, and it also allows the board to establish a chiropractic facility permit. So we'll be working with the licensing committee on developing those regulations as well. We also have all the enforcement authority that we requested, allowing us to automatically revoke a license based on a sex offense, to automatically suspend a license based on a conviction of a serious felony, and then allowing us to automatically revoke a license for a second insurance fraud conviction. So all of those will help us, decrease our annual fees that were paid to the Attorney General's office for legal services. We also got the language to create the exception to the 7-year look back period with applicant discipline involving sexual misconduct. Now we can consider it no matter when it occurred. There's also some minor kind of changes in there about having us distribute a copy of the directory electronically to each licensee. We already have the IT resources to be able to do that. We are going to have to create some sort of process for licensees to opt in if they want it distributed to them by mail. So we'll work with DCA on making that happen, either through the Connect platform or some sort of contact form on our website. And then the language, as it's currently amended, also includes the intent of the legislature to work with stakeholders on the animal chiropractic issue. There is some discussion in the background paper on that potential practice agreement model for animal chiropractic. That was never actually amended into our bill, so all we have is intent language. I do want to point out, when it came to the animal chiropractic issue, the Veterinary Medical Board actually met on June 15th, and they took a position to oppose our sunset bill if it were to be amended to include animal chiropractic language. I've had a few discussions with their board, and we're basically at this point, I'd say deadlocked on that issue as far as which board should regulate animal chiropractic. The board, of course, taking the position that the board should regulate it because it's chiropractic. VMB respectfully disagrees and would want to regulate it. So I don't anticipate animal chiropractic going into our sunset bill. It'll likely be an issue that we'll hear about again next session. And both boards have expressed that we're open to working on language together and collaborating and working directly with committee staff on the issue. But like I said, at this point, we're pretty much deadlocked on who should regulate that. So with that being said, I've got in the meeting materials the sunset bill. I've got the committee analysis. I'm happy to answer any questions as it relates to our bill.
Thank you for that update, Ms. Walker. Questions or comments from the board?
Kristen, can you share any of the committee staff's feedback on the chaperone request?
It was just more of a matter of, I think they wanted to hear a stronger justification on why the existing pathway doesn't quite work for us and why we should be the first through the gate for this new authority. So I think the justification is there. We could definitely bump that up a little bit, but I think at the end they were, with sunset bills, they don't tend to put controversial issues into them. It's more of the straightforward. So I think it's an issue that they definitely heard me on. It's just a matter of we may want to kind of look at that proposal, and then look at some potential other options and try to explore going directly to an author and seeing if they'll carry it as a separate bill.
Okay, great, thanks. And then I just wanted to say a big, big thank you. I was just so pleased we got so much out of this one. So thank you to you and everybody.
I definitely concur with that. That was it was great to get everything we asked for except one thing. Is pretty awesome. Any other comments, questions?
No, thank you also from me.
Okay. Moderator, would you open up agenda item 11 for public comment?
Hi, this is the moderator. We do have a comment. Dr. P, you're going to be seeing an unmute request on your screen. You have 3 minutes to make your comment. Thank you.
Hello, I believe if you can hear me, wanted to say thank you to the Chiropractic Board for continuing to research and look into the animal chiropractic matter, and continuing to advocate for the Chiropractic Board being the regulatory board for licensed and certified chiropractors. Thank you.
Thank you for your comment.
We have no other raised hands or comments online at this moment. I turn the floor back to you, Chair Adams.
Thank you. Agenda item 12, update, discussion, possible action on other legislated related to the board, the chiropractic profession, DCA, and other healing arts boards. Ms. Walker.
Thank you. So you can see compared to our April meeting to our meeting today, the list gets shorter when it comes to legislation that's going to affect the board. A lot of the bills that the board considered in April, for one reason or another, didn't make it out of committee. So we've got a rather short list of bills to talk about today. I'll start with AB 1767, which would require that the board would require each DCA board to adopt regulations to provide guidance on how to determine whether a relationship other than that between a parent and child would prohibit an individual from serving as a public member of a board. So previously, a previous version of the bill just defined what a close family member meant. This bill now broadened it up a little bit and gave more discretion to each program to make that determination. We'll work with DCA Legal on a recommendation for this board to consider, but it does increase our fiscal impact because rather than just specifying it in statute, we now have to adopt a regulation to specify that. So not too much there other than we'll have to work on something and bring it forward for the board to consider. AB 1775, the ward bill, basically requires the board to expand its existing expedite pathway to former military members who are discharged due solely to a federal executive order. We're saying that there's no fiscal impact on that one because the board's already working on regulations that specify the licensure process. So we would just add that provision in there. And then with our existing IT system, it's just a matter of making a very simple update to that system to just ask one more question under the special considerations tab. AB 1811, this bill, I believe it was recently amended, so I don't think the board's seen this one yet, but this bill would require that our workforce data be collected or requested at the time a license is issued, and then also require it to include the hours worked in inpatient and outpatient care, hours worked providing direct outpatient primary care services, whether the licensee accepts Medicaid, and whether the licensee offers a formal sliding fee scale. This one has a minor fiscal impact in the sense that we're going to have to retool our licensing processes to collect the data at the time of issuing a license. Currently, it's through the renewal process. The changes to the survey will be made automatically by DCA. There's no action needed from the board on that one. So just bring that one to the board's attention. We've been continuing to monitor AB 1979 as it relates to the use of AI in healthcare services. This bill is scheduled for a hearing on August 3rd. The licensing committee has been monitoring it rather closely to ensure that the AI regulation that we are developing and that we discussed under agenda item 9 is consistent with this law and also doesn't duplicate it. And then finally, there's Senate Bill 1391 related to retired category licenses. I continue to watch this one and wonder if it's truly a spot bill because it would just simply require that a DCA board that offers retired category of licensure put that on its website. So watching that one closely to see if it gets gutted and amended later on in the process. So with that, happy to answer any questions the board may have about those bills.
Thank you. Any questions or comments from the board regarding agenda item 12?
I would just like to say I definitely support AB 1811. I think that's a great way of us getting some information from our stakeholders and licensees that we otherwise may not be able to get, just through a survey. So I'm in favor of that one.
Kristen, do we have any more background information on what's going on with 1979? Like any conversations that you can share? Or...
I don't have anything specific on it. The bill's been progressing. It likely looks like it would pass. They've they've been kind of making incremental, just minor adjustments to it almost at every committee that it gets to, but it really just protects the autonomy of the licensee to, basically prohibit like a healthcare system from trying to override their own professional judgment, and also, preventing that type of system from replacing them when it comes to, training unlicensed personnel. So it provides some kind of common sense safeguards there, but it doesn't do a whole lot. But it's more so around just really retaining that ability for them to exercise their own independent clinical judgment.
Do we have any, who's opposing it?
That is a good question. Let me see if I could quickly find it. Give me two
While you're
seconds.
looking for that, I'm a little surprised they didn't include like what's been in popular recently was the issue around insurance reviews and using automated systems to approve or deny claims and reimbursement to providers. I'm really kind of surprised that that's not part of that bill, or I'm disappointed. One of those.
It's actually got the bill has quite extensive opposition, led by a number of opponents, including Kaiser and even the California Hospital Association. So their concern is that it would put in some rigid requirements that would kind of step on kind of the evolution of AI, which the licensing committee had been kind of talking about. So we'll continue watching that bill. But there's support from the Board of Behavioral Sciences and the California Nurses Association, and then a lot of the major health systems are in opposition. You got Adventist in opposition, the California Chamber of Commerce, California Dental Association, Hospital Association, quite a bit. So business groups and larger providers like Kaiser and Adventist are in opposition.
Can you forward that to me? Is that?
Yes, I'll send it to you.
All right, thanks.
Any other questions or comments from the board? Moderator, would you open up agenda item 12 for public comment?
Of course, this is the moderator. If you would like to make a comment on agenda item 12, you may look for the raise hand icon at the bottom of your WebEx screen or next to your name. We are displaying instructions and we'll give you a moment. I see no comments online at this moment. I return the floor back to you, Chair Adams.
Thank you. Agenda item 13, review, discussion, and possible adoption of the 2027 to 2030 strategic plan. Ms. Walker.
So within the meeting materials, so as the board recalls, at the April meeting, the board engaged in a strategic planning session with DCA's Solid Planning Solutions. They've they've put together a draft strategic plan based on that discussion. I just want to entertain discussion from the board if there's any feedback or requested edits to that draft before we bring it back to the board in October for final approval. You can have that discussion today, or you can send me some of those comments offline as well.
Comments or suggestions, edits, anything? Do you have any suggestions or edits as you've looked at it, Ms. Walker?
I stumble on the mission statement a little bit. So, because I kind of think when I'm doing like outreach and everything, I kind of end up rattling off the board's mission statement, and struggling a little bit on that one. And it could just be a matter of a little bit of wordsmithing. And then under the goal areas, a lot of these objectives are good. They're measured. They're definitely achievable. There was one in particular, create an electronic CE workflow. I would recommend if we could maybe consider broadening that a little bit, because that's almost something that we're going to just about check off before we even get into this plan. So I think there's something broader we could do to improve continuing education that we could probably incorporate there and still yet achieve it in this plan. But my biggest feedback was around that mission statement, and maybe it's just my reading of it, but it's just a bit kind of hard to rattle off if I was to do an outreach event and give the board's mission. So just little feedback there.
Suggestions on wording?
Not off the top of my head, but I could definitely try to craft something together. When you look at, let me pull it up real quickly so I could reference it, but like the Department of Consumer.
What we had there before. I'm just curious what we had there before, because I thought what we did 4 years ago was pretty good. So I don't really have a comparison off the top of my head.
Well, so our current mission is to protect the public through licensure, education, engagement, and enforcement. Then we also advancing chiropractic competency. So there's just a lot of kind of different things, and then we're kind of missing.
You just froze. You just froze. Are you? Are you there?
Can you hear me now? Because I got a brief kind of interruption.
Yeah, you're kind of freezing and unfreezing.
Let me try without.
Still a little hit and miss.
Dr. Adams, I'm not sure if this helps. I have the mission like right behind me, and I'm just comparing the words. The big difference is the order of enforcement and engagement are swapped, and that at the end, in the former one, we reference chiropractic care, and here we reference advancing chiropractic competency. So it's we moved up enforcement, and then advancing chiropractic competency completely replaced chiropractic care. So just for the literal differences.
It was more just kind of some word changes, it sounds like.
Hi, this is the moderator. Kristen is going to be joining us via a phone, like her phone number, or we're going to be promoting her right away.
Okay. So while we're waiting for her to come on board, is there any comments from the board as you reflect on those that were present at the strategic planning that we did there with Solid? Do you have any suggested edits or comments?
If I understood her correctly, it sounds like she's struggling to express that mission statement to other stakeholders. You know, it's kind of operational. What's that?
Yeah, it's a mouthful. I think that's what she's saying.
Yeah.
It's kind
So,
of
I mean, more, simply, she could just say protecting the public through licensing, education, and high standards of care. We need something that is easy to say, expresses and encompasses, you know, the mission, obviously, but the way it's written is a bit cumbersome. So that would be my suggestion.
Yeah.
And I'd be fine dropping engagement. That may make it a little shorter.
Yeah, I think the reason it was there is that at our last strategic plan, we had focused on doing more engagement, which we did. And I think we want to continue that, you know, that kind of in the spirit of, you know, getting to the schools and, you know, as we've been doing our board meetings at the schools, which you guys started back when you were on the board, you know.
Yeah, but this is public. Remember, this is public, and we are through licensure and education. Education is engagement, right?
Yes.
If we
Yeah.
just want to trim it.
I mean, I personally, I'm okay as it's written. I mean, I think it is a mouthful in some senses, but I don't know that when we're in a situation where we're trying to explain to people what our mission is, that it would necessarily be difficult to convey that. I think it'd be pretty easy. But you know,
Apologies, I got disconnected and reconnected there for a second, but I last I heard was Dr. Azzolino's comments on engagement. And I'm wondering, what about if we move that to maybe the values, so we kind of keep it in the you know, in the mission, vision, values in total, but we shorten up and maybe wordsmith the mission. I don't know if that's helpful.
I think that's a good suggestion.
And my second thought was something that I think, not to add to this, but one thing I've always thought about our vision statement is that I don't know if it always has directly reflected the kind of, I think, what consumers really want out of care, and something we identify in our value statement, of course, and we don't directly say it in the mission either, which is, you know, the public protection is usually through safe and efficacious chiropractic care. And I think we're kind of missing those words. And I think, just as for consideration, maybe somewhere in the vision that California consumers receive safe and efficacious, and then, you know, whatever else we want to add there. And I know that may add to the kind of word salad in the vision, but I just think it better reflects kind of the values that consumers would have and expect, and maybe even define, when, you know, at least preferentially define, or one of the major definitions of public protection is, you know, assuring safety. So anyway, that's always been my thought. We have it in the values, you know, consumer safety through effective regulation, but I didn't know if really that would be my vision, at least, would be that, you know, that's what they're receiving is safe and efficacious care. That would be the number one thing, and I think that would align with what consumers expect. And then the other things are also important, but just my thought.
I like that.
Hi, this is the moderator, Kristen. Can you hear us now? And would you like to go for a mic check quickly?
Hi, yes, I've heard most of the discussion, so hopefully you can hear me.
Yes, we can. Please go ahead.
All right, thanks.
So you heard the comments from Dr. Paris as well about incorporating into the values, perhaps a focus on safety and efficacious care.
Yes, I did.
Is that where you were suggesting that Dr. Paris was in the values section?
Well, there in the vision was what I was thinking, only because we opened that statement with California consumers receive, and I was just envisioning, like, how would I prioritize what my vision would be of what, you know, patients, consumers, you know, the type of care they receive. my thought was that it kind of aligns with what I would want to receive when I get care as priorities. Would be that it's safe and efficacious. And I think it aligns with public protection mission. I mean, there could be potential to move, you know, like innovation to one of our values, and you know, like collaborative. We could, you know, that's already in the values. So, I mean, if there was a desire to shorten it up, I think that would be my suggestion, is just maybe replacing two words and shifting them around. And I apologize for bringing that up in some way, because I know we spent a lot of time on the wordsmithing of these, you know, when we were doing this. But just as long as we're finalizing it, that would be my suggestion.
You know, just one thought is, under vision, you could just simply use, instead of saying quality care, you could say safe and efficacious care. It could read, California consumers receive innovative, collaborative, patient-centered, and safe, efficacious care. Or safe and effective care. That could fit in there. That doesn't sound like too much of a mouthful under the vision.
I have some issues with saying safe. I mean, our procedures, our skill set, all of that should already ensure the safety. Do we have to repeat that?
We don't have to repeat it. I think what I'm hearing from Dr. Paris is that we're talking about the public who may be coming to us uninformed, and that might be something that gives them comfort and confidence that we are, at least as, you know, as a profession, acknowledging that we're putting their safety at the forefront. I know from our perspective, you know, those in the profession, we know how safe we are, but I'm thinking in terms of the fact that we're getting what, you know, 12 to 15% penetration. So maybe there's a large percentage of people that, you know, are uninformed about chiropractic. But I don't want to speak for Dr. Paris. That's just my.
I was waiting on that one, Larry.
What?
I said I was waiting on that one.
What are you waiting on? To not speak for
I don't
Dr.
want to
Paris?
speak for him.
I mean, the vision statement should be what a company or a group aspires to be. And we should already be safe and efficacious. I'm not against to putting that in, but I think when we're speaking of vision statement, the definition is what the group or company aspires to be. So I think that's where we ended up with innovative, collaborative, and continuing with patient-centered care, which there is a lot in the literature on the evolution of patient-centered care and what does that mean. So I think that's how we ended up there.
Well said, Dr. Daniels. I think if anything, we focus on the highest standard, not worried about the things that can go wrong. Let's elevate things.
I concur.
Kristen, are you there?
But considering how much time we all spent on this last time, I'm fine moving it through. Because I know we all had different thoughts and wordsmith this to death, but we definitely want to hear Kristen out.
Where is she?
I'm here. Yeah,
Oh.
I'm just looking.
So my question when you popped off was, at least what I understood you to say was, you're struggling with the mission statement as far as when you communicate it. Is that correct?
Correct. It's a bit of a mouthful there as far as like if we were to build public
Would a
the impact.
suggestion, sorry, so would a suggestion just be protecting the public through licensing, education, enforcement, and high standards of care?
that would be easier. Yeah, I would agree with that.
I mean, because we already have engage, and then we can just move engagement into values, and we can also move or add safe and efficacious care under values as well. So, I mean, they're in there, but just a thought.
I'm good with all that. I just want to remind everybody that we talked about advancing chiropractic competency, because the last thing we need to do is have people stay at the same level saying what we do is safe and not advancing their skills. But I'm fine with either, but I like the change in the mission statement to shorten it.
So Kristen, do you have enough notes and then we can wordsmith it on the side and then bring it back in October, or do we want to just get it done right now?
I have enough input from this call that I could kind of work through it a little bit offline, and then bring it back in October for a final approval. I think I think I have what I need. I think hearing the mission, I agree with keeping advancing chiropractic competency as well. I just think maybe we pull one word out. So let me I definitely have good feedback from the board, so we can work through that offline.
Yeah, you may not have heard it, Kristen, but I was suggesting just pull out engagement and put it elsewhere.
I believe I heard pulling out engagement and then putting it under values. I would
Yes.
agree
Correct.
with that.
Yeah. I think those are good suggestions. And then on your goal 1.4, if you feel like if you come up with some other wording that, that you want to, change there, I'm sure we would be okay with that, because you're right, with the Connect system, we're pretty much already achieving that before we've even implemented it.
Yeah, let me come up with a recommendation there as far as just broadening it up a little bit. So yeah, if we could potentially replace that with swap it out for another similar objective, but with a different focus. So I'll bring that to the board in October as well.
Okay. All right. Sounds like you feel like you have what you need. And is there any final thoughts or comments from any of the board? Okay. Well, then let's move to public comment for agenda item 13.
Hi, this is the moderator. If you would like to make a comment on agenda item 13, you may look for the raise hand icon at the bottom of your WebEx screen or next to your name. We are displaying instructions and we'll give you a moment. No comments. I'll turn the floor back to you, Chair Adams.
Thank you. Agenda item 14, future agenda items. Are there agenda items that anyone on the board would like to have added for future agenda? For a future agenda?
Yeah, I just wanted to, it was put on last time, but I wanted to bring it forward again, just as far as discussion or moving forward with the board's ability for site inspections, just kind of across the board. Making sure corporations are what they are, there's actual place, etc. But I brought it up last time, and then I'm not sure if it goes here, but I'll just throw it out there. I just I don't know if we need DCA's approval, but if we could really look into using Fieldy or a similar device, AI Scribe, for our meeting minutes, so we can ease up staff and be more efficient. I don't know if that's a conversation for the board or on the side, but I just think we need to become a little bit more efficient. So that's what I have.
Yeah, I second that. I think Fieldy or a like product would be really helpful in helping staff collate the minutes, at least giving a framework. Other suggestions for future agenda items from the board? Hearing none, moderator, would you open up agenda item 14 for public comment?
Hi, this is the moderator. If you would like to suggest any future agenda items, you may look for the raise hand icon at the bottom of your WebEx screen. And we are displaying instructions and we'll give you a moment. Comments or raised hands, I turn the floor back to you, Chair Adams.
Thank you. Okay, we will now go into closed session.
Dr. Adams, can I add one thing to the future agenda items? I'm sorry.
Sure.
I didn't want to interrupt. I had suggested, I think last meeting, maybe a couple meetings ago, there was, and I believe public comment was supported in public comment also was the discussion or moving forward a discussion around the ability to have some hands-on adjusting ability at continuing education for technique and having us kind of clarify that ability.
I think that'd be a good item. Yeah.
I think it's on future agenda. I don't remember which meeting, but I know I put it out there a couple meetings ago or a meeting ago. So if we could circle back to that, I much appreciate it. Thank you.
And along that same lines, I would say, Kristen, can we also, if there's something that we can do, I don't know if we have a history of it or go back, and what happened, give a little history of what happened that prompted that in the first place. I've heard different things, so I think that might be helpful, is if we have a background on what prompted that policy to change. I have my ideas, but maybe there's a historical record of it and why that became kind of a policy for technique aspects. Okay. Anything else? All right. Then we will move to closed session. Or do we need to do a public comment on 14?
Yes. Yes,
Okay.
please go ahead. Since you added an additional item, let's go ahead and open public comment up again.
Yeah.
Hi, this is the moderator. If you would like to make a comment on item 14, you may look for the raise hand icon at the bottom of your WebEx screen. We are displaying instructions and we'll give you a moment. See no comments or raised hands, I turn the floor back to you, Chair Adams.
Okay, thank you. All right, we'll now move into a closed session.
I'm going to be moving you guys in a closed session. Please give me a moment. You'll receive a request. Please click on that to move to the closed session.